patient's position has been modified to tip her back. The area has been anesthetized, and we now will proceed with the removal of these remaining maxillary teeth. They include the molar, these bicuspids, and the anteriors. While we're looking at them, you can see that the bone contour is quite variable. Here, around this remaining very solid bicuspid, is a roll of bone with an undercut above it. That also will be true around the canine region here, farther forward, and also around, just turn a bit toward me, Ms. Selvey, around this maxillary canine on this side. We have these bicuspids to think about. Let's, before we proceed, have a look at the x-rays of these teeth to get us oriented. Here is the remaining molar, and we see it has 3 roots. It's involved with periodontal disease. We'll see if we can use that to demonstrate root division, even though it's not particularly indicated. We'll try to demonstrate the manner in which it's done. The well-supported bicuspid we will be removing perhaps first, as well as the cuspid, and we'll carry on with the removal of these widely spaced residual central roots that are so extensively involved, and then the teeth on the opposite side as well. So we will turn our attention first then to the exposure and the flap reflection to gain access to this premolar and cuspid area. We'll recall that because we need access for all of these, we won't demonstrate oblique incisions, but instead we'll stay over the ridge crest with our number 15 blade and come forward around the distal of the bicuspid. And then we will go into the interproximal, and we'll take this papilla base and carry around in the usual pregingival margin fashion. We have a lot of chronic inflammatory reactivity of these tissues, and they're quite hyperemic. As we start to reflect the flaps, we use the small end of the elevator. We go into the base of the papilla until we find solid bone. Then we reflect that papilla base. Now I'll go around to the distal here and see if we can get the flap started there. Start the flap around the concavities, not over the convexities. If you start over the concavities, you're more apt to be able to strip the periosteum away and not tear it. Whereas if you start on the convexities, it's apt to remain adherent in the valleys that are there. Now, as the flap starts to be reflected, we have pretty good view of the contour of that buccal plate, how prominent and heavy this bone is. Because the bone is atrophied between these 2 teeth and is very heavy around this one remaining tooth, as we take a hold of that tooth with a forceps, we're very apt to crack a large quantity of bone out in the fracture of an alveolar process. We would like not to do that, and so we will remove some of this undercut by means of instrumentation. We could start with a Rongier forceps and use that to reduce some of the bone. Down below, we demonstrated the use of the rotating instrument. Here we can place this Rongier with the beaks in that manner and contour some of the undercut bone away. Now, that's an area that would have to be contoured anyway, so that it is not sacrificial of bone support. We can look here with a little more adequate flap reflection at the bone overlying the cuspid as well, and we'll try to reflect that flap up slightly. Because of the periodontal disease, several of these incisors are excessively hypermobile, and flap does not reflect too easily there. We'll have some suction again. Trying to release the adhesions where chronic scarring from periodontal disease created that. Once again, we have some undercut here, and I'll take those rongeers once more, and we'll try to just trim some of the collar of prominent bone around from the cuspid itself. What we'd like to do is remove these two teeth without fracturing the alveolar process. So we'll take the number 150 instrument now. I have direct vision, and I'm carefully, just open widely now, applying the beaks of the forceps one beak at a time. I slide up on the palatal side, I slide up on the buccal side, and then giving the maxilla some support, I'm trying to manipulate then this tooth in a direction of both the palatal and buccal manner. In so doing, I find a path of more or less reduced resistance to that manipulation, and on each excursion of the forceps, I try to move the tooth in the direction that it is yielding in that manner. We next will approach the cuspid and again apply these beaks in a similar manner. And the cuspid is a conically rooted tooth, and we shall try to give it some rotation in the same manner. Cuspid's rather long, as you can see, but we have not fractured any of this alveolar process, you see. So by reducing some of the reinforcement of it, we actually have conserved bone. Now we can proceed with the reflection of the flap more adequately for these remaining teeth. And when we have that all reflected up at the free gingival margin, flap will return to this field and proceed with the forceps delivery of some of the remaining teeth. The flap has been reflected over these remaining teeth, and we see once again a lot of hidden irregularity in these bony contours. Suction, please, right here. You can see the great concavity and this rather sharp spur that is there. Once again, we're going to give that a little bit of pre-extraction contouring in order to avoid some of the resistance to the delivery of those teeth. And we also, in this instance, will use, since all these teeth are to be removed, we can employ the elevator as a means to luxate them partially before they are individually removed. One has to be very careful in the application of elevators as to the vectors or the forces that are generated. But here we are going to take all these teeth out, so there's no problem in that distribution. As we indicated earlier, because the cuspid root is so long, we tend to remove it first, placing the beaks of the forceps well up on the root, and then proceeding with the mobilization of the canine. Sometimes you can support the maxilla rather well here by grasping it in this manner, and in just giving a little rotation to that, we see the length of the cuspid root that was delivered, and also the conservation of the bone. No bone fracture. We want to avoid fracture of the bone. Here, this very loose central incisor will rotate out with no difficulty. I think I'll confine my efforts for the moment to the bicuspids on this side, and we will eliminate the remaining teeth here, and we'll suction the mouth carefully. The assistant must be rather careful in keeping the field clear and the pharynx clear with a patient who is this far in a supine position. So we are then eliminating the remaining bicuspid teeth, and we'll be returning to trim both bone and soft tissue in that area in a moment, but I now will complete the removal of this right residual incisor root and the lateral. That will then account for the removal of all of these teeth. Well, one thing we might show here, sometimes the lateral incisor has a root configuration with a dilaceration to the distal. In that event, it can be grasped mesiodistally and given some motion to the distal as well, and that can often compensate for that particular peculiarity of the lateral. So we're rotating and moving it somewhat to the distal as it delivers. So we now have those teeth removed, and I'll inspect the region by sliding the periosteal elevator underneath the flap to expose the entire labial surface. And we're looking for areas of sharpness, of undercut, and in general the contour is fairly good. Anything that's residual will be responsive to a bone file, which we will now use. Here is the application of the bone file, cutting on the draw stroke. That's the only way that it is effective. And using a rest finger, so we have things well under control. And I'll be reflecting this palatal flap at least enough to get over the alveolar crest once again. And I have to trim those soft tissues out sharply. Here we're returning to the alveolar process where we are using the file for final contouring. And the soft tissue trimming will be accomplished with sharp instrumentation, supporting the tissue well, making incisions that are slightly shelved, that have a slight undermining effect, keeping the field as clear as we can as we move along here. And then these bits of papillae turn toward me, please, Mr. Selby, a little bit. That's fine. These papillae will be trimmed away, and then we'll proceed with the closure in a manner as we demonstrated before. May I have the Rongier forceps, please? So now I will trim this by grasping some of that tissue, and the assistant will clear the beaks of the forceps before we go back, as well as keeping the field clean by suctioning. Now we have completed some of the soft tissue trimming and bone modification here, and are just about ready to close. Now, as we have established some reasonable hemostasis, we have been into this area and irrigated things out well. We have removed the periodontal pathology. We've removed the periapical pathology with curettage, taking a small curette and going up into the alveoli. Now we'll bring these landmarks together. First of all, we'll anchor the midline just as we did before with our initial suture right in the midline. And so here is the interradicular bone crest, and we have that soft tissue trimmed. We also will now proceed through the labial. In general, as we'll try to demonstrate in a moment, it's better to insert sutures through the more widely reflected flap and into the more stabilized one. That amounts generally then to suturing, for the most part, from the buccal and labial to the lingual and palatal, since most of the flaps for access are reflected from the buccal surface. We'll next proceed with a continuous locked suture distal to the last tooth and insert our first anchor suture. We can suction perhaps in the back of the pharynx slightly there. And we'll use the continuous locked type of closure as we did in the anterior region down below. So when we get this triple tied, I will cut just the short end of it here, and with a needle I'll continue to make these interlocking loops of continuous locked suture. We're going here to the first point of bone bridge, and I'm going perpendicular so I go through the full thickness of the periosteal flap. Now, it's not possible to get through both flap margins appropriately when they're spaced at this distance. So to get equal depth and equal distance and bites of tissue for securing of the sutures, we must do it in that manner. So we have then the first of the series of continuous locked sutures that we will also use on this side. Here we have completed this suturing of these flaps. You can see they're now readapted fairly well over the modified bone. We'll extend our incision posteriorly, and then we'll try to reflect the flap from the buccal. I'm sliding in now. You see the patient's mouth is partially closed together. And with that jaw partially closed together, I can get way back here and intervene to get the access that I need. Whereas if she had her mouth propped widely open, I would not be able to do that. So we will follow our incision through the periosteum with the periosteal elevator. We'll try to get down to some kind of a bone plane here that will reflect for us so that we can get this buccal plate exposed. After I have this flap lifted, I'll try to engage it with the tip of this retractor, and you may see just a little bit more of our immediate field. I think if we get that little remnant of soft tissue out of the bifurcation area, that will be fine. Now you can see the bifurcation zone exposed. If there were a heavy collar of bone up here, we would have to remove that bone to get down to this level. Now there'll be some vibration and noise here. I'm going to go into the bifurcation of the two buccal roots, and I'm penetrating that bifurcation. I'll follow that penetration with a cross-cut fissure burr. And the cross-cut fissure placed here will be used next as we go in to cut off these roots. Let's try to slide under there again. There we can see it, and we'll move in to try to divide these two buccal roots. I'm cutting these roots off at an angle that is inclined toward the occlusal in order to leave us some root to work with. Now I'll try to do the same thing on the distal. So we have the buccal roots divided. Next we'll see if we can take the crown of the, we have a 77R elevator here, and we can go in there and see if those buccal roots will crack off, and they did. At least the mesial one did. And that at least showed our approach. Now, if you can open a little bit, please, we'll proceed with the removal of the palatal root. And lots of pressure here for just a moment. So when these teeth have any degree of divergency in the tripod of the several roots, it can be helpful to separate the roots and bring them out in this manner. Now the distal, we just cut off the mesial buccal, and we'll take this out, and the distal buccal also came along, so we have only the mesial buccal root remaining. We can suction in there once again to show us the field. And I'll use a periosteal elevator to more adequately control this flap, which is otherwise escaping. We can suction again. I'll see if I can find that mesial buccal root, which is right here, and we'll rotate that in a manner that will cause it to deliver. We can see the edge of it being turned to distal, and we'll see if then we can grasp that and remove it with a conservation of the buccal plate, which is the whole objective of division of roots. The mesial buccal has a little bit of a resistance to it that's increasing really more than that little hemostat can control. So I will go to a root forceps and use that to engage it. That's fine. A little more adequate control with the root forceps, and here we see the mesial buccal root being removed. So that accounts for the multi-rooted molar, and we next will examine, perhaps with that retractor we can see a little better, these remaining contours on the buccal. We'll trim that extra soft tissue, but all this buccal plate has been preserved, and that might have been fractured if we had merely put the forceps, a molar forceps, on that isolated remaining molar. I'll take the 15 blade first, and as we did with the other mandibular isolated molar, we'll take a wedge section out of these redundancies on the distal and also on the mesial. And then we can retrieve that tissue with the small rongeurs, which will help to grasp it and control it. Use most anything to do that, but that's one way to get it out of the field, and doesn't damage the instrument. The rongeurs can be used to manage soft tissue, but should not be used as a forceps on enamel or crown surfaces. So that flap then should return to place, and we'll show the final suturing here in just a moment. We now have completed the preparation of this mouth for dentures. We can see that there has been conservation of alveolar ridge in both the mandible and in the maxilla. The continuous locked sutures have been placed. There's been good buccal bone preservation. There are no bilateral severe undercuts, but we also have not excessively trimmed the bone. So we would expect that this patient, now being free of her diseased teeth, periodontal disease, will be in better health, and we hope that by this demonstration we've demonstrated the applications of instrumentation in tooth removal. We'll thank Mrs. Selby for her participation in this demonstration.